So our next speaker is Dr. Anjay. He's a consultant pediatric pulmonologist. He is the director of Pediatric Cystic Fibrosis Service, covering a significant area of Northeast England. He's based at Norfolk and Norwich University Hospital in Norwich. Dr. Anjay, a hearty welcome on behalf of Zulekha Hospital, Dubai, and from the UAE team.
Good morning. Deepu, am I okay to start? Or?
Yes, please.
Okay, sorry, I got disconnected briefly. Good morning, everyone, and greetings from not so sunny Norwich in the UK. It's a great pleasure to be invited to speak at this event organized by Dr. Deepu Abraham. I probably missed my own introduction. I was slightly disconnected, but as you heard, I'm a pediatric pulmonologist in the UK. I work in Norwich in the UK. And I'll be talking to you about pediatric cystic fibrosis. I'm going to share my screen in a minute. I hope you can all see my slides. So we have around maybe 25 minutes to speak about cystic fibrosis and current concepts. Brief introduction, I did mention I work in Norwich, where I lead the cystic fibrosis service here. This is a regional specialized service running for the last quarter of a century, and we are based on the east coast of the UK. We had a children's hospital here since 1852, and this is the second oldest children's hospital after Great Ormond Street Hospital. So why are we speaking on cystic fibrosis? I know you come from a variety of different hospitals and backgrounds. You may or may not have come across a lot of patients with cystic fibrosis, but you must be aware that this is a serious disease. It's a genetic condition, and where there is no newborn screening, which we will come to in a minute, diagnosis is often delayed, thus leading to complications. So early recognition is very important. This is a complex multi-system disease needing multiple specialists and a big team of people. And in fact, this is a model of a disease where teamwork and working together has markedly improved outcomes. And this model can be then applied to many other diseases. In the last few decades, there has been a huge change in our understanding of the disease, including how the disease happens, the genetics, and what we can know about it. And I will briefly mention some new drugs which have come into play in the last few years. So clearly the prevalence of cystic fibrosis will vary depending upon the country, given that it's a genetic disease and there are many different mutations which can cause the disease. It is thought that around 100,000 people in the world have CF. Clearly it depends upon where you work and what's the genetic makeup of the population. I haven't worked in Dubai myself, but a lot of my friends work there, and you do have cystic fibrosis there as well, although perhaps not as common as in the West. There was a view that cystic fibrosis is primarily a Western disease many years ago. Not at all. All ethnic groups, all countries have cystic fibrosis, but it does vary as to how much there is. Some of it is, of course, under-recognized. There has been reports of children who likely had cystic fibrosis for a long time. I'm sure you know all about the basic symptoms of cystic fibrosis, which include severe failure to thrive and loose, smelly, fatty stools, and recurrent chest infections. And anecdotally, people used to say they even taste salty when you lick them. And this has been the case in many ancient records. But it was only in 1930s and 40s that we came to understand what we now know as cystic fibrosis. And in fact, the name comes from the changes in the pancreas. It is not due to lung changes. Cystic fibrosis refers to cysts and fibrosis in the pancreas. In those days, it was an autopsy diagnosis. Unfortunately, children used to die before 1 year of age from severe pancreatic disease. And Dorothy Anderson made the first description of this, as you can see. Well, things have moved on since then. And if you were to discuss an overview of CF, as we are doing today, we have to touch upon all of these issues. We don't have much time to go into great detail. Even if I spend 5 minutes on each of these, that will take us over the time. So I will focus on a key concepts of each of these rather than going into a lot of information. Some of the interesting or useful stuff I will highlight a bit more, and then we can have some discussion if there are questions. So we know that this was a genetic disease based on family inheritance. It is an autosomal recessive disease. So what you will normally find is both parents are not affected, but clearly some of the children might be affected. We know about the genetics in much more detail now. When I first started giving this talk many years ago, my slides were a bit more truncated because the genetics were not a key feature of the talk, but now it is a very important part of the talk because we are talking about treatments based on your genetics. And I'm sure you must have heard of the most common mutation called Delta F508. In the UK, that is the most common, and perhaps so in many parts of the world. So I don't need to tell you about autosomal recessive inheritance. You know that if mom and dad are both carriers, you can have 1/4 chance of there being a healthy child, 1/4 chance of there being an affected child, and 1/2 a chance of there being a carrier. We need to discuss a few basic concepts of genetics before we move on. We will aim to do that in the next few slides. So I mentioned that the mutation happens on chromosome 7. And what does this actually do? So there is something called CFTR, which is cystic fibrosis transmembrane receptor. This is a membrane spanning receptor. It has many functions, and for the purpose of this talk, I will keep it fairly straightforward. For the moment, we will assume that the main role of this receptor is to control your chloride transport. And it has a wide distribution in the body, including lungs, liver, gut, etc. So there is essentially a gate which controls how sodium moves in and out of a cell and various membranes. And that is controlled by this particular gene. And that is of relevance to our discussion. So I'm sure all of us know at least some concepts of what I'm discussing, but I will take you through some basics. So the flow of information is, of course, DNA, RNA, and then protein. The DNA in the cell give instruction to the RNA. With the help of ribosomes, we make proteins. The proteins move to where it needs to work. And in this case, the protein is actually the CFTR, which controls the chloride transport. So why is that important? In a normal airway, if you look at it, the chloride moves normally, and along with it, you have normal movement of sodium and water. Again, this is a very simplistic discussion, but for the moment, we will keep it there. And that then leads to moist airways with normal mucus and normal movement of secretions. If you don't have the gate, if the gate is closed, for example, here, there is no chloride channel, all the chloride remains here, no water moves, and everything becomes thick and dehydrated and sticky. And that is exactly what happens in cystic fibrosis. But things are not so simple. Again, if I was giving this talk many years ago, I may have skipped this slide, but now we need to know this. The mutations are classified into many different types. So this is a DNA here and at the bottom, and this is DNA, and then you have the RNA, the ribosome, and then the protein moves to the surface. And this is on the left, you can see the normal situation, but you can have a variety of abnormalities. You can have shortened protein, misfolded protein, the gate doesn't open, and or the gate is faulty. So depending upon the mutation, there can be a variety of abnormalities, and that affects your clinical features, which I will come to in a minute. So to keep it simple for this discussion, conceptually, we are thinking of two different things. One is there is a change in the ion composition in many parts of the body. Along with that, there is a change in your mucus. And these together cause all the issues in cystic fibrosis. So if you look at organs which has both these issues, pancreas, liver, lungs, and gallbladder, there's one issue there. But for example, in the sweat gland, there is no mucus. You just have a change in your ion composition. So what happens in the lungs then? So you have decreased volume, increased mucus. This leads to obstruction, which then leads to infection. Then you can't defend against bacteria. It leads to inflammation. So this is a slide which summarizes exactly what I was trying to say. This is the whole pathway: DNA, protein, abnormal transport, abnormal secretions, blocked ducts, infection, and inflammation. This can then explain most of what you see in cystic fibrosis from the top to bottom: sinusitis, abnormal sweat chlorides, pancreatic disease I'll come to in a minute. Of course, any severe suppurative disease leads to clubbing, and you can get liver disease and gut disease as well. Interestingly, male infertility is a separate feature of the disease. It's not due to mucus issues or due to any ion problems. I'll come to that also separately. But what about the sweat glands? In the sweat glands, normally there is an active reabsorption of your electrolytes, and that is significantly affected in cystic fibrosis. So you then excrete more sodium and chloride in sweat, with the result that your sweat will be more salty in cystic fibrosis. And people used to come to hospital with severe salt depletion in hot climates. Doesn't happen so much in the UK, but does happen in hot countries. And that gives us a good chance to test the sweat and do the so-called sweat test, which I'm sure you heard of for cystic fibrosis. So this is the gold standard test for cystic fibrosis. Again, I'll come to that later. So far we have discussed a very rapid overview of the genetics and the pathophysiology. Essentially, we are discussing a disorder of chloride transport caused by dysfunction of cystic fibrosis transmembrane receptor caused by mutations in chromosome 7, which can explain all the clinical features of cystic fibrosis. Again, we knew about this only for the last 20-30 years. So when would you, as a clinician, want to think of CF or to consider testing for cystic fibrosis? So increasingly in almost all developed countries where there is a newborn screening program for CF, you may not come across this at all, because what happens is the newborn screening laboratory will get a positive result and that will forward it on to the specialist in CF, who will then start straight away treatment and follow up. So one option is you do the confirmatory test following a newborn screening test. But of course, it can present to any of you with one or more clinical features, or somebody might come and say they have a family history of CF, or antenatal scan sometimes show some bowel changes or something else which may suggest CF. So in all these situations, you may need to think of cystic fibrosis. So there are international consensus definitions of what makes you think of CF and when would you confirm CF. So to demonstrate somebody has cystic fibrosis, you need to have one of these clinical features, which is chronic sinopulmonary disease, gastrointestinal abnormalities, salt loss, or some other rare conditions. Or you can have a family history, or you do it because there is a positive newborn screen, and then you move on to a confirmatory test, which includes a sweat test or genetics. I'll come to that in a minute. This is important to say because in some cases you can get genetic abnormalities of no clear clinical significance. For example, if you do random testing for genetics, you may pick up 2 mutations, perhaps linked to cystic fibrosis, but not always. And if there is no symptoms, are we really saying that this child has a disease, or is it something else? So there can be some ambiguity if you rely only on genetics without any clinical context. So when would you suspect that somebody has cystic fibrosis? Again, depends upon where you work and what kind of pediatrics you do. But the vast majority of these children are pancreatic insufficient and hence will present in the first few weeks or months with fatty stools, malabsorption, and failure to thrive. And as time goes on, they will also have recurrent chest infections. But bear in mind, 10% will present with meconium ileus in the newborn period, which is important because even if you have a screening program, you wouldn't have the result at that point. So this is a typical growth chart. You know, you start off normally and then you kind of drop off the growth chart. And meconium ileus, I'm sure you're all familiar with. I might come back to that in a minute. And this is what it will look like on the X-ray. Of course, there are other causes of meconium ileus. In a white British population, where cystic fibrosis remains the most common cause, although there are, of course, other possible causes. You can also think of clinical features by age. Clearly, in the early age group, you find pancreatic deficiency and malabsorption, recurrent chest infections leading to failure to thrive. You can get salt depletion and some liver issues occasionally. You can present later on in life with bronchiectasis and intestinal symptoms, including obstruction. And you can also get unusual things like severe polyps and sinusitis as a presenting feature. And increasingly, there is recognition of adult, milder or atypical CF, which can present only with some of these things, such as sinusitis or infertility, for example. Bear in mind the infertility is due to congenital absence of the vas deferens, not due to any mucus issues or due to any ion problems. So there are classical presentations and rarer presentations. Another way of looking at it is a progression from infancy to adulthood. So there's a nice graph summarizing what I am trying to say. So depending upon the initial presentation and the age and the severity of the mutation, this can present at different age groups, as you can see, which is why it is still very important to have a very high index of suspicion in any of these symptoms. If you don't know what is going on with any of these clinical features, you need to think of cystic fibrosis and rule it out. The gold standard remains what we call a sweat test. It's a very interesting test, but we won't go into much detail today. It takes some skill to collect the right sweat. You can stimulate sweat production by pilocarpine iontophoresis, and then it goes to the lab. It can be done in almost everybody apart from very, very small or premature babies. And then you check the sweat for sweat electrolytes, and the gold standard is sweat chloride. I know some labs do sweat conductivity, but the gold standard is sweat chloride. And as I showed you in the previous slide, in cystic fibrosis, the chloride will be elevated. So if you have a sweat chloride more than 60, it supports a diagnosis of cystic fibrosis. Less than 30 is pretty much normal. And between 30 and 60, there is, in fact, ambiguity, which sometimes can create challenges. But most cases of classic CF will have a chloride more than 60. And that remains the gold standard for diagnosis. You can, of course, check for mutations, but the problem with that is that there are nearly 2,000 mutations documented. And this is available on the international database called the CFTR2. There is no lab in the world which will do all these 2,000 mutations for you, even if you request it. In the first instance, this is time-consuming and cumbersome and expensive. All that you can do is, depending upon which country you work and what is the ethnicity of your population, you can screen for some of the more common mutations. For example, I could say I will screen for maybe 25 of the most common mutations in my country, and that will cover maybe 90% of CF. And still, if you want further testing, you speak to the lab and then extend your mutations at great cost and effort. So for this, you need to know the ethnicity of the patient and the type of mutations in your country. And this is just one chart showing the most common, and the most common at the top is Delta F508. More recently, there has been studies in practically every country, and this is a nice paper from Arab countries summarizing the mutation. And here also, the F508 is the most common, but some of the other ones are different from other countries. So you need to know your local spectrum and speak to your laboratory to make this test. But if you have an abnormal sweat chloride, you have confirmed the diagnosis irrespective of genetics. That is one of the key messages. Okay, we have to move on with a lot of things to discuss. Many countries now have newborn screening programs. I won't go into great detail, but the fundamental principle of that is you measure something called immunoreactive trypsin in the blood of a baby. That will be elevated if you have cystic fibrosis. So if that is elevated, you then proceed to further confirmatory testing with genetics to try to find 2 mutations. If you do find 2 mutations, clearly you report it as CF suspected, and it goes to the specialist. If you don't find the 2 mutations, this could have been a false positive, or you may have missed something, but most likely it's a false positive IRT. So this is a very good program. And in fact, I must say that I work in an area of the world where this happened for the first time 40 years ago. And only last year, I organized an international meeting to celebrate this achievement. So this is me with the founder of the newborn screening program who started this for the first time in the world. Since this was started in East Anglia, then other places in the UK, Canada, etc. started it, and now it's practically there in most countries. I'm aware this is happening also in many Arab countries over the last 5 or 6 years, although there are some countries without any screening, which is unfortunate. This is in fact the first baby who was ever screened and found to be positive. She's no longer a baby, of course. She's 40 years old and doing quite well. The point of screening is you pick up things early, and then you prevent or delay severe problems. And as recently as maybe 10 years ago, there were reports saying cystic fibrosis is misdiagnosed when there is no screening. But now, of course, there is screening, and outcomes should be improving or should have improved. We'll move on. So everyone knows about cystic fibrosis as a lung disease, which is of course true. There may be no lung symptoms in the early stages, although if you do careful lung function, even in newborn babies, you can find abnormalities, but there may be no symptoms. As time goes on, you develop the classic features of wet cough, and then you go on to more serious things. You can get atelectasis, then inflammation, then leads to bronchiectasis, clubbing, and then ultimately you develop severe lung disease. And if you don't do anything, you end up in respiratory failure. And unfortunately, some people will die from it, and some people will require a lung transplant. So our aim is to prevent this whole progression of disease. So I can see some questions which ask which week of gestation sweat test is significant. So Mamata, the answer is sweat test is significant at any age, but there are technical challenges in doing it in very small babies. So we don't normally do it below 2 kilograms. We often get called from NICU saying baby has meconium ileus, can you do a sweat test? We normally say wait a few weeks, in the meanwhile send genetics and treat as if possible cystic fibrosis. But our lab and our nurses can do it in practically any age group apart from the very, very small group. So it's not about the relevance of the sweat interpretation, it's about getting the right amount of sweat, which can be challenging in small babies. Thank you. And if you don't do anything, or even if you do things on a long period of time, you get mucus plugging and bronchiectasis, especially in the upper lobes. And this is exactly what we want to prevent. Even people who are stable will get occasional exacerbations characterized by increase in sputum production and decreased appetite and feeling of being unwell, which needs aggressive treatment. So what is the aim of treatment? Clearly, we can't cure the disease straight away. Our aim is to maintain lung function or even delay this. So if you look at this data, with each passing year, our outcomes are much better. The blue line at the top is the last few decades, whereas this red line is from several decades ago, at which time, even by the time you are 12 or 13, your lung function starts dropping quite steeply. But now it is much more steady, and our hope is that at least in the pediatric or early life, your lung function will be very good, and that is mostly what we are seeing. Similar picture here. So this is 6-year-olds in the at the top, and 26 is all at the bottom. And as you can see, with each passing year, our outcomes are much better, and this is exactly what is happening. So I have told you a lot of things, and if you put it all in one slide, this is what it will look like, and then that gives us a chance to do something about it. You can address the problem at multiple levels, as you can see here, and we will run through a few of those. How do you manage the lungs? So these children need aggressive surveillance and aggressive management. Even if they have a wet cough for a few days, you will give antibiotics. It's not like other children where you will say it's a virus and go home, etc. Antibiotics will be given at very high doses for a longer period of time. We see them very frequently in clinic. They are all on an aggressive physiotherapy regime and on a lot of extra treatments. We monitor them very closely. And other thing to say is infections in CF are very different from other infections. This is the UK national data, and they get unusual infections with sometimes unusual bacteria. So in the early years, which is this orange line here, you get mostly Staphylococcus and Haemophilus. And then even standard antibiotics like Fluclox or co-amoxiclav might be okay. As time goes on, you get this blue line, which is Pseudomonas, which is the arch enemy of cystic fibrosis. And then you get all kinds of other bacteria, which may not necessarily affect people with healthy lungs. So Staphylococcus is common, and you can treat with Fluclox. People have tried giving preventive antibiotics. It is a subject of study even now, but it might work. Pseudomonas is very important because even if it doesn't cause any immediate symptoms, on a long time, it will colonize your lungs and cause severe inflammation, scarring, and drop in lung function. So I don't have a polling option today, but if I did have it, I would have asked you this question: what will you do if a child comes and you notice that there is Pseudomonas in the cough swab? Clearly, it will be overseen by a specialist. But if you ever see Pseudomonas in a sputum, you should at least think of CF. And if child already has CF, child will need aggressive treatment, even if child is absolutely fine. And the answer is, you need to treat it very, very aggressively. You will give a combination of systemic treatment, which is usually oral antibiotics, ciprofloxacin, and nebulized antibiotics. And that can eradicate the Pseudomonas if you pick it up quite early. Pseudomonas, we shouldn't underestimate. It's an important topic, but I don't have time to discuss in great detail. But bear in mind, it's very important in cystic fibrosis. Aspergillus is another thing. Not just infection leads to a special condition called allergic bronchopulmonary aspergillosis, where you get inflammation, high IgE levels, wheezing, and even bronchiectasis, and that needs steroids. So you can see here IgE levels going up and then coming down with treatment. So that again, you may be confused because child may come with coughing, wheezing, you are giving on antibiotics, nothing works. Then you realize it's not an infection, it's actually an inflammatory reaction to aspergillus. Then you check the blood test and you find the diagnosis. There are other infections, including non-tuberculous mycobacteria, increasingly recognized recently. Again, no time to go into great detail, but it needs appropriate treatment. So antibiotics are given at higher doses in multiple forms, oral, IV, nebulized. These doses are quite different from standard doses. You need to give special cystic fibrosis doses. And we are very strict about cross-infection. We don't want this multi-resistant bacteria to spread between patients. So no cystic fibrosis patient can ever meet anybody else with cystic fibrosis. They don't go into a waiting room in a clinic. Even in school, you shouldn't share the room with any other cystic fibrosis children. And in clinic, we are very, very strict with infection control. And this has reduced infection in cystic fibrosis. I will skip this slide, but just bear in mind there is something called Burkholderia cepacia, which is a very dangerous bacteria for cystic fibrosis. We don't see it often, but if you see it, it's a major problem. How do you monitor this? We don't take much of a chest X-rays. We go by clinical features and lung function. But if you do take it, it's when you think of a complication, or you take it once a year as a routine review. You can get things like atelectasis, nodular shadowing, bronchiectasis, etc. But ideally, you want to avoid what you see here. The lungs should be relatively okay, not like this, at least in pediatrics. You do a CT scan if you think of complications or if there is severe disease. And if you do it, you might find all these features like mucus plugging, bronchiectasis, particularly the upper lobes, because there is some radiation. We don't want to do it routinely in children. So question from Heba suggests, do all CF children need prophylactic antibiotics? Heba, that's a very interesting question. We may not have much time to answer it. Do you mind if Deepu, shall I answer the questions now or wait for the end?
You can do them at the end.
Okay, that's probably better because otherwise it may take some time. Okay.
I will summarize the questions for you so that it doesn't get repeated.
Thank you so much. So we will move on with this presentation. Okay. So how do you monitor lung function? So again, another interesting topic. There are many things we can measure, including FEV1 particularly and FVC when you blow into a spirometer and you get some values and you get a trend like this. So in this graph, this top line here is 100% lung function, and this is probably 50%. So this was a child who came to me from another country with already severe lung disease. Normally, most of our children have lung function 80% and above, which is a marker of good health. Some people, of course, have low lung function. This child was already dropping by the time they saw us. And this is around 60%, then dropped to around 50%. So I referred him for a lung transplant because at that stage, you can't do much more than what you're doing. But then as you can see, something remarkable happened here. And, you know, something really significant happened here. And the lung function now has gone up to nearly 80 to 90%. So that is remarkable. I will come back to that in a minute. But you can use lung function as a tool to monitor your respiratory status and track what is going on. And that is a very useful tool. Sometimes even if you're quite well, your lung function starts dropping and then you think why that is happening. Okay. Oh, the slides are stuck. Probably let me see if I can. Yeah. So another very important part of the chest management is physiotherapy. Again, that's a whole topic in itself. Normally, when I get time, I also call my physiotherapist to speak in this meeting because that is a cornerstone of CF treatment. You need to clear your lungs of secretions of all the thick mucus, without which none of your antibiotics is going to work. Because of lack of time, I'm not going into it, but I will show you some other interesting information regarding mucolytics and hydrators. So as you know, there is normal airways with normal liquid and normal mucus. CF, you have reduced liquid and quite thick, if you might call it that way, and thick mucus. So to combat that, there's a specific drug called pulmozyme or DNase. So the sputum in CF contains a lot of DNA from the neutrophils. And you can actually cleave that using this enzyme called DNase, which makes it into smaller pieces. Then you can cough it out easily and do physiotherapy more easily. So just look at the dramatic difference in the sputum before and after giving this treatment. It becomes quite thin. So if you imagine somebody's lungs is full of this thick stuff, you just can't do anything. Your antibodies are not going to do anything. But here it's much thinner, and then that means that you can effectively clear it. And you can treat it effectively. So, but the moment you stop the treatment, lung function drops. It's important to take all these treatments every day. But of course, this needs some work. You need to train them. You need to give them a nebulizer. It needs a lot of oversight in the initial few days. Most people above 5 or 6 are given this treatment. There is also something called hypertonic saline, not as effective as DNase, works in a slightly different way, promotes coughing and enhances your clearance. And as you can see here, the lung function is better even with hypertonic saline, but not everyone needs it, and it's not as good as DNase. You don't necessarily need bronchodilators in all cases, but as we can see, we are giving a lot of stuff directly into the airways. And it's important to give it in the correct order. Otherwise, if you give, for example, the inhaled antibiotics first, all that you're doing is you're going to cough it out following your mucolytics. So because of lack of time, I will move on very quickly to non-pulmonary, and then we may have questions at the end. So similar to the lungs, there is thick mucus and obstruction, which then leads to pancreatic destruction and pancreatic insufficiency. That leads to digestion problems and on a long-term diabetes, because of course pancreas produces insulin. Similarly, liver, you get liver disease and cirrhosis. If it happens in the intestine, you get intestinal obstruction or even constipation. So that's a quick crash course in non-pulmonary features. 90% of CF children are pancreatic insufficient. I know that you know the clinical features. You can actually test for it in many different ways. Again, no time to go into detail, but fecal elastase is now the preferred test. It is very sensitive, specific, not invasive, and easy to do. And that is not affected by the treatment. So you can do it even if the child is on treatment with pancreatic enzymes. The aim of treatment is to maintain normal growth, give normal nutrition, and prevent any nutrient problems. So if you have pancreatic insufficiency, you need to correct that by giving pancreatic enzyme. The brand name we use is called Creon. You may use something else there. Unfortunately, Creon can be inactivated by the stomach acid. So you need to have a special coating for it so it will survive intact till it reaches the intestine. And once it reaches the intestine, everything is okay. You can then absorb your food from this enzyme. You need to give fat-soluble vitamin supplementation, because if you don't absorb fat, clearly you don't absorb your vitamins as well, and that can lead to serious problems. So in summary, nutritional management involves giving pancreatic enzyme replacement, giving vitamin supplementation, and making sure you get enough calories. It's a quick case study. Somebody was on the right management, giving enzymes, but still not gaining weight despite having a lot of supplements. Then needed to have a gastrostomy, and as we can see here on the growth chart, the weight was dropping off, but with our intervention now the weight is clearly going up and the height is going up, and this is what we want to see. You can get constipation, of course, but in severe cases you can even get intestinal obstruction. This is the older child's equivalent of distal obstruction syndrome, and that needs early recognition and management with laxatives or sometimes even barium, or very rarely surgical management. I won't go into all of this. I won't claim to be a specialist in all of this. All of this can happen in cystic fibrosis, needs appropriate monitoring, surveillance, and management. You need to screen for diabetes at a certain age. You need to screen for liver disease. They can present with all of these things. So be aware of multi-system issues in CF. This is my cystic fibrosis team. Main thing to say is a teamwork. A lot of people, pharmacists, social worker, nurses, physiotherapists. And it's not just doctors who do all the work. The teamwork is very important. Psychologists is very important. These children and parents are under a lot of stress. You need to collect data and compare your practice against international national standards to make sure you're doing the right thing. So this is UK national data. We are somewhere in the middle. This is lung function of patients. So if you are really low, you need to think why that is low. So this is all working. Of course, it is working. If you were born in CF 50 years ago, you would have died by the time you are 1 year, unfortunately. But now you can see that even in 2010, the life expectancy increased to nearly 50 years on an average. But now with new treatments, I'm sure it is at least 60 for most children. And that is, of course, an average. But some people will, of course, have early and severe lung disease. But as we can see, all the teamwork and all the interventions has improved things significantly across the last few decades. I will finish off with Deepu for 2 minutes, if that's okay with this discussion. This is exciting time for cystic fibrosis. We now know what causes it, so why don't we address it at a molecular level? People are trying gene therapy. We are not quite there yet, but very excitingly, we have drugs which can correct the fundamental abnormality with regards to the protein and the receptor. So very quickly, there are all these different types of mutations, and we have drugs which can target each of these problems. For example, if the gate is closed here, you have drugs which can open the gate. And that means that your flow rate will become normal, and you might even have a normal sweat test in some cases, which is amazing. So fantastic topic to discuss, a lot of interest, a lot of research, but be aware that now there are in fact drugs for most of these mutations which can correct the underlying molecular defect to a great extent, leading to remarkable improvements. I will show you a quick case study. This was a child, severe lung disease, the same child I showed you earlier, frequent antibiotics considered for lung transplant, lung function dropped to 40%. There is this new drug called Orkambi. I won't go into details. At that time, it was not licensed in the UK, but the company was able to give us as a special request because his child was in severe lung disease. As you can see, even the X-ray started to improve remarkably within a few months. I've never seen something like this before. And look at his lung function. This is 40%. And I started the treatment here in 2018. And now it is 70 to 80%. And that is the average lung function for many people in my clinic. And the child was then discharged from the lung transplant clinic because we don't need any more lung transplant, and he's doing quite well. Even his clubbing regressed. I was really amazed to see. And his inflammatory markers became normal for the first time in his life. And as you can see, he's got low albumin throughout, and now it's become normal. And immunoglobulins are a marker of inflammation. They started coming down. So as I said, the future looks quite bright as long as we have early screening, early recognition, appropriate teamwork, an appropriate combination of treatments like I have showed you. Most children with CF, although it is a severe life-limiting chronic disease, with modern treatment, we can be sure that most of them will have a very good quality of life and a good life expectancy as long as we follow these basic principles and modern treatments. I think I went there. Shall I stop sharing the slides, Deepu? Thank you.
Thank you, Dr. Anjay, for that brilliant presentation. There are a few questions. I will summarize them so that the few questions are on the sweat test. It is about the timing of the test, how early it could be done, how reliable it is for preterm babies.
Yeah, so as I already said, it is not about the reliability. It's mostly about getting the right quantity of set. So we don't normally try it in anybody below 2 kg. There are, each country has its own guidelines. That is our guideline. So in extreme preterms also we can't try. So normal advice on calling from NICU is, if it's a term baby, wait for a few weeks and we could try. If it's a preterm baby, there is no way I'm going to try. I will do the genetics at that point and then wait for the baby to become a bit bigger before we can try the sweat test. But that you have to refer to your own local guidelines. This is a UK guideline. Normally, you have to be at least 36 weeks gestation and more than 2 kilograms body weight to have a proper test.
Sure, thank you. It's a question from Dr. Prakash. While using crayon in cystic fibrosis patients, what things needs to be monitoring and how frequently?
A very useful question. So first of all, you have to give the crayon properly. How you give it depends upon if you're a baby or an older child. In a baby, you have special preparations. You need to give it with what we call apple puree. You need to give it with any food containing fat. Even milk has fat, and you need to give it at the beginning and in the middle of having that food. So once you start crayon, the question is, are you giving the right amount? We can roughly estimate that by the fat in the food, but then you monitor that by primarily symptoms. Are you getting tummy pain? Are you getting fat in the stools? Are you getting loose stools? And also, are you growing okay? If none of this is an issue, you can be sure that you are giving the right amount of crayon. So that needs frequent monitoring by dietitians, very frequently in clinic in the first few weeks. After a few years, people get used to it, and even patients can, to some extent, self-regulate how much crayon they take. But we check that using features of pancreatic absorption and also by your growth pattern.
Sure. The question from Dr. Heba: at what age should we screen for pancreatic insufficiency?
So if you have a newborn screening result for cystic fibrosis, you should screen for it straight away. Many children already have symptoms. They may be losing weight and having loose stools, but it's a very simple test to fecal elastase. So if you have a newborn screened child who you already think has CF, do it straight away. If you find somebody, so essentially, I would suggest doing it as soon as you think of the fact that somebody might have CF. Somebody is failing to thrive, straight away do it, then you know what you're dealing with. If somebody you think has CF, then do it straight away. We should, when you say about CF, it's a multi-system disease. You should define, does the child have lung disease, child have gut disease, or both? And fecal elastase abnormality will immediately suggest that you got gut disease. And 90% of CF people do have it, and it's a simple test, so no reason not to do it.
Thank you. There are a few questions from Dr. Mamta, Dr. Rubia. It's about the antibiotic prophylaxis. How early should it be started?
So I can speak about this for a few hours because I'm actually a part of a national study looking at it. I'm not the investigator, but I'm the local collaborator, so to say. I will say only two things because we don't have much time. Historically, in the UK, we have given prophylactic flucloxacillin for many years, and that seems to have improved things. But nothing is quite that straightforward. If you knock out one bacteria by giving antibiotics for 20 years, there is a risk that other bacteria might overgrow and fill that ecological space. And there is a small risk that Pseudomonas might overgrow, for example, if you kill off all your Staphylococcus. So there are pros and cons to that approach. Now we have a trial called CF Start from Liverpool, looking at is it really good to give long-term prophylactic antibiotics. We don't have the results yet. It may take several years. So the sum total of it is, yes, some people do give prophylactic antibiotics. Yes, it might prevent infections in some people. If you do start it, we start it straight away after diagnosis at birth. And we stop it by around 6 or 7 when Staphylococcus is not so much of an issue. But there might be some unintended long-term consequences, which we don't know at the moment. So you have to rely on your local guidelines and local practice. I still give it in some patients after discussion because the trial results are not out yet.
Sure. Thank you very much. There are a few more questions, but I think with the limitation of time, we will wrap it up here. Absolutely. Thank you very much, Dr. Anjay, for that brilliant talk.
It's a pleasure.